Hello everyone, welcome to Gyan's Academy. Today we are going to discuss tumor lysis syndrome. Before we dive into today's topic, I would like to request you please like, share and subscribe our channel on various platforms. So let's move on today's topic. Tumor lysis syndrome is an oncologic emergency in which intracellular content from tumor cells are released into the bloodstreams. This is seen in hematological cancer such as acute leukemia and non-Hodgkin's lymphoma. Tumor lysis syndrome can occur after cytotoxic therapy. In tumor lysis syndrome, the lysis of tumor cells releases potassium, phosphate and nucleic acid into the bloodstream. This release can result in severe metabolic disturbance including hyperuricemia caused by the catabolism of nucleic acid into uric acid, hypercalcemia due to the release of intracellular potassium, hyperphosphatemia from the release of intracellular phosphate, hypocalcemia as a result of phosphate binding to calcium, reducing serum calcium levels, elevated lactic acid from the metabolic process of rapid dying cells and the body's response to stress. These imbalances can result in renal failure, cardiac arrhythmias and other several complications necessitating prompt recognition and intervention. Signs and symptoms includes nausea, vomiting, diarrhea, decreased urination. Clients may experience arrhythmias which can lead to palpitations and syncope. If not treated, TLS can cause sudden cardiac death. Muscle spasms are often associated with weakness, numbness and tingling. The client may experience tetany. In addition, clients may experience confusion, irritability, hallucination, delirium and land up with the seizures. An important complications of TLS is acute kidney injury which typically presents with oliguria, that's a no urine output or decreased urine output. Diagnosis of TLS is done by clinical findings and history. Upon the lab test, a complete metabolic panel will reflect electrolyte imbalance, typically showing hypercalcemia, hyperuricemia, hyperphosphatemia and hypocalcemia. In addition, LDH level are usually decreased. Other diagnostic tests include kidney function tests which often shows increased serum creatinine. Blood urea nitrogen will be high. A urine analysis usually reveals a presence of uric acid crystals in urine. Finally, an electrocardiography can be performed to assess for cardiac complications. Treatment of TLS mainly involves close monitoring of electrolyte levels, urine output and heart function. Treatment begins with IV isotonic IV fluids to correct electrolyte imbalance. For hypercalcemia, IV insulin and dextrose can be administered to shift excessive potassium into the cells, reducing potassium from the blood levels. If potassium levels are below 6.5 milliequivalent per liter and there are no cardiac symptoms, polystyrene sulfate K-oxalate can be used. Phosphate binding agents such as aluminum hydroxide and a phosphate restricted diet are recommended. Hypocalcemia usually resolves once hyperphosphatemia is managed. Hyperuricemia can be treated with medications like haloperidol, which decreases the production of uric acid, or with rusburicase, which break down uric acid to be easily excreted by the kidneys. If potassium, phosphate or uric acid levels are too high, urgent hemodialysis may be needed. In conclusion, key points to remember for prevention of tumor lysis syndrome include taking certain measures before starting chemotherapy. These measures involve aggressive IV hydration and medications like haloperidol, rusburicase to prevent a hyperuricemia. Thanks for watching. Don't forget to visit www.completenursingsolution.in or scan the barcode to access practice question for NCLEX exam. Stay tuned for more videos. Bye bye for now.